Hi, everybody. Nice to see you again. So we're going to talk about addressing what is not there. So when we think about all of the different things that can happen in Parkinson's disease, we have to really also make sure that we're not neglecting and that we also really do a good job of understanding what Parkinson's disease psychosis and cognition and the role they play, how to screen for them, how to understand them within the context of Parkinson's disease, how it is that we can treat them. Remember, this is an advanced therapeutics course. It's the Advanced Therapeutics in Movement and Related Disorders Congress. And this is just a virtual presentation, but our goal is to really create expanded content and really focus on advanced therapeutics, And so our goal before therapy is addressing what's not there. And what's not there might be hallucinations, delusions, the experiences that our patients neurobehaviorally might feel. So if we move on to our next slide here, and we're going to always bring it back to 1817. And when I first started doing presentations publicly in movement disorders, that's the 34 years including preschool that I talked about in the previous lecture. Right at that 34 years including preschool, that was probably around 200 years after the essay on shaking palsy was described. So that was back in 2017. I still remember doing presentations saying it's been 200 years since Parkinson's disease was first described. And you'll see a historical context to things, understanding them can be really helpful. Seeing the actual manuscript here on the slide of what James Parkinson was really trying to kind of put together was an idea of this kind of hypomimia, which is reduced kind of gesturing of the face, hypophonia, low volume of speech, micrographia, this kind of a smallness in handwriting, flex posturing, difficulty swallowing, shuffling like gait, freezing of gait, this hesitancy to our stride, were many things that that James Parkinson described. But understanding in this next slide the evolution of Lewy body pathology, when we think about Parkinson's disease, remember the brain is a complex organ, right? And so when we think about the way these alpha-synuclein protein depositions in form of Lewy body, how this protein deposits within the neuron, what we have to think about, what part of the brain is affected, right? If it's the area that affects dopamine levels, like the substantia nigra in the midbrain, then we might see low dopamine levels, which might lead to a lot of these motor symptoms. But you might know now, after hearing a lot of what has been said, that this isn't all about motor symptoms, right? Symptoms that sometimes are more troublesome or just as equally troublesome can be non-motor symptoms, cognitive changes. And that might have to do with this Lewy body pathology being more part of that cortex. As you see on the right brain, what we're showing you is that trajectory of alpha-synuclein spreading from the gut all the way up through the brainstem, then the pons, then the midbrain, and then through the cortex. Cortex is that eloquent part of the brain, the part of the brain that we think with, that we remember, that part of the brain that helps us with attention, with speech output. And so that's the cognitive aspect to care. This is the UK Parkinson's Disease Society for Brain Bank diagnostic criteria. And what it does, it helps us really understand the motor symptoms, right? You need bradykinesia. You don't need tremor. You need bradykinesia, which is slowness of movement with either rigidity and or a rest tremor, 4 to 6 hertz, and or postural instability, changes in walking, gait instability, and gait changes. And so that's very helpful in understanding Parkinson's disease from a motoric lens. But let's try and understand kind of the processes, just generally speaking, that lead us to a diagnosis. What's our diagnostic workup like as a movement disorder specialist after 34 years, including preschool? What we see here is we might get an MRI of the brain, which might rule out a vascular type of problem that might lead to Parkinsonian symptoms, those UK Brain Bank criteria, meeting those slowness of movement, difficulty with walking, infarctions, vascular changes can lead to that, especially if seen in the basal ganglia. Also, we look for expanded or enlarged ventricles. Things like normal pressure hydrocephalus can look like potentially like a secondary cause of Parkinsonism. And then we do a DAT scan, our nuclear medicine neuroimaging biomarker here. We see in Parkinson's disease patients, we might see, rather than see 2 comma-shaped structures, you see here caudate and putamen, we see reduction of that, which is very helpful. Rather than 2 comma-shaped structures, we might see 2 periods or reduced kind of dopamine active transporter activity, indicating that there's a reduction in dopamine. So here we can see, aside from our neurologic exam, our UPDRS motor score, aside from staging, where we might do our Hone and Yar staging from 1 to 5 in our clinic, we're also looking at handwriting. We're looking at spiraling. We're seeing if, for example, what kind of tremor we're evaluating. Are we seeing how fast, what's the frequency of the tremor? In patients with Parkinson's disease, we might see micrographia in the actual spiral, might be small. People with essential tremor, if we're trying to evaluate just the tremor, might have this moderate amplitude of oscillations. And then dystonic tremor, we might see a directional preponderance, as we see here. But understanding all of these aspects are part of our diagnostic tools. Our clinical biomarker, our examination, is so important in movement disorders and neurology. So aside from that, I think one of the most valuable things we can talk about today in this presentation is making sure that we don't neglect the cognitive aspect to care, right? Making sure we're evaluating patients for their in terms of their mini mental state examination or their Montreal cognitive assessment. We're making sure we get imaging of the brain. We're ruling out causes of dysfunction, cognitive change, like we see with those laboratory values that we order. We make sure we're screening for depression. Maybe we're doing an expanded neuropsych battery of testing. We can even go as far as do genetic testing in our workup. And the reason behind it is to understand the overall whole body, all organ system that's affected in Parkinson's disease. And so we've already seen a presentation on these non-motor symptoms, but I think reinforcement of similar ideas is important, especially when I bring up the part of this cognitive neurobehavioral presentation about addressing what's not there, is looking at the amount of depression in Parkinson's patients. You see there anxiety, psychosis, dementia, cognitive impairment, periodic confusion, apathy, fatigue. And these are all things that are kind of underneath a cognitive umbrella, but due to Parkinson's disease, and they're things that need to be addressed. And there might be Parkinson's disease movement symptoms, as you see with this iceberg image. It's just the tip of the iceberg, right? Below the surface, there's a multitude of other aspects, different parts of the body, different parts of the brain that are also affected. Now, let's see how Parkinson's disease advances further. So, we tend to think about the non-motor symptoms, but later, as the disease progresses, usually after Parkinson's disease, tremors, rigidity, and all those other features kind of are established, we might start seeing those cognitive and neurobehavioral things, the symptoms, continue to evolve and become more and more intense and persistent. Things like psychosis are important to understand. As more of the moderate to advanced stages progress, that's when we tend to see more psychosis and the neurobehavioral aspect of Parkinson's disease become more pronounced. And in addition to cognitive changes, dementia, right? You see anywhere after 10 years, you might see more psychosis, more dementia, more cognitive change. And so understanding that is part of Parkinson's disease and how it is we're going to treat it, right? So if we look at the MDS UPDRS motor score, that's very, very helpful. We have 1 through 4. We can't neglect, if you look at the non-motor aspects and the experiences of daily living, we can't neglect those cognitive changes, the depression, anxiety. There are treatment, in terms of an advanced therapeutics course, there are treatment options for these patients. And I think it will be very, very helpful in understanding that a little bit further. So what about non-motor symptom screening? How do we do it? Aside from asking questions, I'd like to kind of review, based on guidelines, in the movement disorders world, what it is that the non-motor symptom questionnaire can really elucidate. And sometimes, using screening questions, putting on your detective hat and making sure that you are screening for problems with attention and memory, like you see on the right over there in domain 5 of the non-motor symptoms. You're making sure you're asking about concentration, their patient's ability to maintain attention, their ability to remember things, maybe not long-term, but more short-term things. How hard has it been? How often do you forget things? Things like, where are my keys? Where did I leave them? Things like that can be very, very helpful. And executive function, understanding executive function, utilizing things like technology, something that in the recent year or two, based on a lot of this kind of virtual world we've been living in, A lot of our patients have noticed that it's been hard to kind of learn and relearn and understand technology. So all of these things in terms of attention and memory shouldn't be neglected. Let's look at domain 4, perceptual problems, hallucinations. Are we experiencing frank visual hallucinations? Are we experiencing presence hallucinations? We're going to go into that a little bit more. Now we're going backwards, but let's look at domain 3, mood and cognition. Are we making sure we're addressing depression, anxiety, apathy? Are we making sure we're addressing the cognitive aspects? Because there are treatment options that can happen. So aside from the level B evidence based on guidelines to utilize our Montreal Cognitive Assessment Screening Tool, our mini mental state examination, our cognitive screening tools. Remember, there's also a level of evidence to be able to screen for depression using different scales, geriatric depression scales. The Beck Depression Inventory is something we can think about. And the reason is, in cognitive change, making sure we rule out a pseudo-cognitive experience where things like pseudodementia, depression can lead to cognitive change. You can have what are called psychomotor slowing symptoms, slowness of thinking, almost like a slowness of processing, kind of like this RAM on a computer, for example. That ability to that agility, cognitive agility can slow down. We call that bradykhrenia in the cognitive world of Parkinson's disease. And so when we think about depression and Parkinson's disease, we have to make sure it's a multimodal approach. First, we have to screen and we have to make sure we're addressing it, right? You might want to use medications, as we see in the bottom, SSRIs, SNRIs, tricyclic antidepressants. Sometimes dopaminergic therapies can be helpful in improving or boosting mood, stabilizing that. And then we want to make sure we're using, as best we can, different approaches. You might want to optimize caregiver support, community support, psychiatric care, utilize social workers to help us with non-pharmacologic interventions to help our patients, and then make sure that we understand the chronology of events. Remember, we have to know when depression exists, when anxiety exists. Is it a wearing off phenomena, or is it something that's always there? We might see wearing off anxiety, for example, or depression or cognitive change. And that might be separate from a long-standing kind of also diagnosis of depression or anxiety or dementia. So this is a Montreal Cognitive Assessment. It's out of 30 points. And so what we're really doing here is we're addressing the different components to cognition, right? Visual, spatial, executive function, like you see on the top there. We ask the patient to draw a clock, name. We're going to ask them to remember 5 words. A lot of us are very familiar with this, but utilizing this tool and kind of teasing out what aspects of cognition are affected. Is it an inattention issue? Is it a language issue? Is it something that has to do with delayed recall? Remember, delayed recall can give us a lot of information. If we have trouble encoding information, like we see in Alzheimer's disease, even if we give a patient category cues about the 5 words we've asked them to remember, or if we give them multiple choice cueing, like rather than just ask them, what were those 5 words? If they can't remember, for example, face, and you say, well, was it arm, leg, or face? If they're unable to, even with those kind of multiple choice cueing or cues in general, if they're unable to remember despite that, usually that kind of throws us into an encoding problem as opposed to a retrieval problem. In Parkinson's disease, we have issues with retrieval. Now, our neuropsychological testing can be very, very important. Understanding, especially for baseline information, big academic centers, we can offer this, and in general, all over the country and the world, neuropsychological evaluations can be very, very helpful in understanding what components of memory or cognition are affected. And we also utilize neuropsychological evaluations before making a determination of whether or not a patient can go ahead with DBS surgery. So not neglecting this cognitive part of Parkinson's disease is part and parcel into our approach and how it is that we treat patients successfully. So now let's look at Parkinson's disease with cognitive change and dementia. And what we see here is that we might actually see, based on this, this data, we might actually see cognitive impairment at first appointment, when we're first maybe even thinking about Parkinson's disease based on this information. About 19% of patients may have had cognitive impairment at the time of diagnosis. And there's different data out there, but understanding that cognitive care is part and parcel to even our initial evaluation is very important. And that's important then to think about prognosticating and understanding based on the neurodegenerative nature of this condition, over time, and you see a little bit of that gender preponderance of a little bit more in women than in men based on data. We see that over time, we're going to see in about 30 to 80% of patients this increased lifelong risk of dementia, Parkinson's disease dementia. Now, let's think about cognition, because if we're screening for cognitive change, and we might ask a patient, how's your memory? And the patient's partner might say, hey, my memory's fine. But remember, there's different types of memory. There's long-term memory, there's short-term memory. But then let's not forget that cognition is really what we're looking at, right? Executive dysfunction, that ability to draw a clock, that ability to execute a task, the ability to draw a cube, following instructions, following a recipe, even executing a task such as walking is very, very important. So executive function is part of cognition. Attention is part of cognition. Remembering where you put something, following someone's train of thought, following along with reading or a movie, for example, is part of attention and inattention. So remember, cognition is not all memory. It's actually this combination of memory, executive function, and attention. And so in Parkinson's disease dementia, that cognitive profile is more about the impairment of memory is very much a short-term memory dysfunction. Long-term memory may be there, but it's more of a retrieval rather than an amnestic pattern, right? That encoding on that Montreal cognitive assessment becomes so important. When we really unpack what our cognitive tests can give us, it's more than just a number. It's a lot about understanding the different aspects. So if we can see in our Parkinson's patients that they're actually having trouble with executive function, with retrieval of thought, with retrieval of words, that can be helpful in understanding the Parkinson's disease cognitive profile. And then executive dysfunction, like we said, problem solving, shifting sets, understanding concepts easily, cued behavior internally, tasks that require planning, sequencing. We lose that capability, unfortunately, in patients with Parkinson's disease and cognitive change. And then attentional impairment, right? Reaction time, vigilance might be different. And we might actually see fluctuations either based on this on and off idea of medications, but also fluctuations of cognition in patients with Parkinsonism. And so what is it that we try and do for cognitive dysfunction in general is we're trying to make sure we've first ruled out an acute confusional state as we think about, right? And we've truly diagnosed dementia. That's part of the difference, right? And we do the laboratory testing, and patients, they might have this subacute onset of cognitive change. First thing a lot of the time we're doing is making sure our patient doesn't have an infection, especially in the setting of cognitive impairment, right? Patient calls us, says, I've been feeling very confused, or a patient's partner says, patient's not themselves, something's not right cognitively. They're confused, maybe psychosis that happens in a subacute or acute fashion in a patient that previously didn't have psychosis. Even that can be an encephalopathy, an infectious encephalopathy. So making sure that we're kind of understanding an acute confusional state and differentiating it from a long-standing dementia is very important. That's kind of a foundational approach. When we think about memory domains, it's important to understand that this long-term storage of memory happens in a different place than where it is that the part of the brain that has to do with retrieval. The frontal lobe, that executive power of our body, of our brain, comes from that frontal lobe. And we know that accessing, retrieving information comes from the frontal lobe. And in patients with Parkinson's disease, we might see some frontal lobe dysfunction. And that's kind of the real estate of the brain. And they kind of reaches down that frontal lobe, those pathways will reach down into the temporal lobe to kind of pull out to the surface some of these things that have been stored. And so that's kind of how the frontal lobe functions in terms of retrieval. So understanding that is important conceptually. So we might see in patients with Parkinson's disease impaired executive function, right? We might have some changes in insight, understanding about our condition and understanding about just other concepts. We talked about memory retrieval, that being an impaired executive function. Planning, poor planning, things like keeping up with appointments or even just planning how to draw something. Verbal fluency is also an executive function. So verbal fluency is very important to understand. in addition to kind of mental flexibility, jumping from one concept to another in a quick way is also an executive function. And so in patients with Parkinson's, we see inattention and executive dysfunction. And we know that that relationship exists because of that connection between that prefrontal cortex and all the other parts of the brain where things are stored. And that executive function really does help control complex attentional capabilities as well. So what about the impact and understanding Parkinson's disease, dementia? When dementia becomes the centerpiece of a diagnosis, can oftentimes be described as distressing even more so than the motor symptoms, and the caregiver burden is high. So what about diagnosing of mild to moderate Parkinson's disease with dementia, right? And understanding what that means in terms of when Parkinson's disease was first elicited, when we started having symptoms that led to the diagnosis, and understanding the chronology of events can be very, very helpful in distinguishing between the different cognitive diagnoses, right? So how is it that we establish a Parkinson's disease with dementia diagnosis is very much dependent on when dementia occurred. So if you had Parkinson's disease motor symptoms for at least 2 years before the diagnosis of Parkinson's disease with dementia, then we might say that this is a Parkinson's disease with dementia case, as opposed to the other sorts of dementia, like a Lewy body dementia. Lewy body dementia, we might see within the 2 years of motor symptoms evolving, we might see cognitive change, or we might even see cognitive change precede the motor symptoms of Parkinson's disease. So all of those things play a role in understanding, are we dealing with Parkinson's disease and dementia? Are we dealing with dementia with Lewy body or Lewy body dementia? So is it dementia with Lewy bodies, or is it Lewy body dementia? What are Lewy bodies? So Lewy body really, a Lewy body is essentially, it's a hallmark brain abnormality that we see in Parkinson's disease and in Lewy body dementia. Parkinson's disease is a Lewy body disease. Lewy body dementia is also a Lewy body disease. It just depends on where it is that we see underneath the microscope in the brain the alpha-synuclein and the protein deposition and the hallmark Lewy body micropathology within the neurons. And here we might see, whenever we think about one neuropathology, we might think about the other neuropathologies. It's not uncommon for us to see different proteins accumulate in the brain of Parkinson's disease patients. You might see both beta amyloid accumulation, tau accumulation within the brain, in addition to alpha-synuclein deposition. So it really has to do with this kind of complex protein accumulation disorder when we think about cognitive dysfunction as well. So let's kind of take a quick trip down Lewy body dementia world to understand it a little bit better. And so remember, Lewy body dementia is a diagnosis that's made, and it's very much reliant on understanding the degree of cognitive change and cognitive fluctuations that occur, especially early on in the condition. When you think about Lewy body disease and Lewy bodies in the brain, remember they're intraneuronal. You see them both in Lewy body dementia and Parkinson's disease. But when we think about the cerebral cortex, the amygdala, hippocampus, the brainstem, all these parts of the brain can be affected with Lewy bodies, and they can lead to different things. If you see Lewy body accumulation in the brainstem, that's where we might anticipate more sleep disturbance, things like REM behavioral sleep disorder, changes in alertness. If you see that the hippocampus is disrupted, that's a memory center, right? The hippocampus is a memory center. Amygdala, that's where we see mood changes, right? That kind of instinctive underlying emotional center right there is in the amygdala. Cerebral cortex, when that's affected by the protein accumulation and neurodegeneration, that's when we see hallucinations, which are characteristic to Lewy body dementia, thinking and logic impairment, right? So the neuropathology can be shared, right, between patients with Alzheimer's disease, Parkinson's disease, Lewy body disease. I kind of mentioned that in terms of the protein accumulation in patients. You might actually see changes even on the FDG PET scan in patients with diffuse Lewy body disease. You might see more global hypometabolism. And in particular, you might actually see in the occipital lobe the visual center, you might see some hypometabolism in addition to more global dysfunction in dementia patients. Of course, our DAT scan is very useful if we do determine that we also have a reduction in dopamine active transporter activity, or this reduced dopamine levels as registered by the DAT scan. That can be helpful diagnostically in understanding, are we dealing with a Parkinson's disease cognitive profile? Are we dealing with a Lewy body dementia cognitive profile, or a Parkinson's disease cognitive profile? So here we see, very importantly, now we're thinking about cognitive change in the setting of Alzheimer's disease versus Parkinson's disease with dementia. What we're showing you here, actually, this is important therapeutically, as this is an advanced therapeutics course. What we're showing you here is, in comparison to an unaffected brain, we actually see that in Parkinson's disease with dementia, in comparison to Alzheimer's, there's actually more of a cholinergic deficit. There's more of a cholinergic deficit in Parkinson's disease with dementia, which kind of sets up the concept as to why it is that we utilize some of these therapies. Now, if we look at treating dementia and cognitive impairment in Parkinson's disease, what we're showing you here is that based on the actual guidelines set forth by the Movement Disorder Society, what we see here is that the guidelines actually show that it's possible that the utility of acetylcholinesterase inhibitors may be possibly useful to clinically useful. Rivastigmine does have research suggesting that an acetylcholinesterase inhibitor such as rivastigmine may in fact lead to decrease in falls. And there were previous trials utilizing rasagiline, which is not an acetylcholinesterase inhibitor, as you see here, more investigational, but which might show that there might be some cognitive benefits to utilizing something like rasagiline, as was seen in the Moderato and recognized studies in patients with Parkinson's disease with mild cognitive impairment. So we utilize things like rivastigmine in our patients, and we utilize things like rasagiline. In cognitive change, memantine is also has been studied for Alzheimer's disease, but based on guidelines, investigational in terms of practice implications. So as you see here, a lot has been studied in treatments for mild cognitive impairment in general. You think about things for level B evidence, level C evidence, but what we're showing you here is that the major recommendations for patients that have mild cognitive impairment is to use validated tools to diagnose. Clinicians might actually think about modifiable risk factors, such as exercise or non-pharmacologic therapies, things like cognitive therapies done, cognitive therapy done by a speech language pathologist. There are non-pharmacologic things that we can offer. Remember, when we think about the behavioral aspects, that also plays a role, but the cognitive aspects, when we think about what agent to choose, clinicians may choose to offer a cholinesterase inhibitor or not. It is level B evidence based on guidelines, but if we look at the clinical data within the Parkinson's disease world, the utility of a medication such as an acetylcholinesterase inhibitor like rivastigmine has been shown to be clinically useful. So there's a lot that has been studied and a lot that we need to learn more about, both in the pharmacologic realm and the non-pharmacologic realm. And if you look at rivastigmine in Parkinson's disease with dementia, based on this clinical trial published in 2004, looked at rivastigmine for dementia associated Parkinson's disease. Essentially what we showed is that the change from baseline in the ADAS-Cog, which is a clinical research cognitive tool scale, we actually saw that those that were taking rivastigmine showed improvement with statistical significance in terms of at 16 to 24 weeks in comparison to placebo. And the patients that were on rivastigmine actually did show some marked to moderate improvement in terms of cognitive capabilities based on those outcomes. So utilizing it for cognition can be thought of based on data as helpful and effective. Also importantly is looking at the evidence there about rivastigmine and falls, right? And something that we may not necessarily think is combined is using a cognitive therapy, cognitive medication, and looking at data that might suggest that we see a reduction of falls if you look at the top right graph there in the patients that were on rivastigmine in comparison to placebo at week 32. And so falls per month may have been reduced in that treatment group. And so there's some data here to suggest that cognitive medications may in fact help our motor capacity. What about our neuropsychiatric screening, right? Psychosis, we may want to ask patients about whether or not they feel the presence of a person or an animal or a spirit. That's called the presence hallucination. We may want to ask about passing hallucinations. We may want to ask about, which is something that passes in the periphery. We may want to ask about hallucinations that come in the form of an actual being or person that can be seen and described and sometimes heard. We might want to ask about auditory hallucinations, because all of those things can be important in understanding, feeling shadows, and then illusions where things change shape. For example, like a belt on the floor might look to a patient momentarily as an animal or as a snake. And then we want to compound that information and understand it within the context of asking about agitation, asking about depression, anxiety, if there's any emotional lability, apathy, indifference. Understanding what's depression and what's apathy also can be helpful therapeutically. Disinhibition or aberrant motor behavior, restlessness, nighttime behavior, getting up in the middle of the night because of sleep fragmentation, identifying that and understanding whether or not it has to do with disorientation, why I got up and got dressed in a patient with cognitive change in Parkinson's disease, as opposed to why I got up. Was I having a REM behavioral sleep disorder episode where I was worried, or was I feeling delusions where our patients might actually feel fearful of people in the house, persecutory delusions versus delusions of infidelity sometimes can happen in our patients with Parkinson's disease with delusions or psychosis. So if we look at the understanding of what Parkinson's disease psychosis really means, we can see that in patients with Parkinson's disease with dementia, hallucinations and delusions can be seen. The overall psychosis prevalence can be up to 50%. Dementia with Lewy bodies, 75%. So understanding that aspect of things is very important. Understanding that Parkinson's disease is not just a dopaminergic issue, but also acetylcholine changes occur, as we mentioned earlier in previous presentations, serotonin changes, norepinephrine changes, right? The locus ceruleus, which produces norepinephrine, is affected. The nucleus of Raffi that produces serotonin is important to understand that it also can be affected. The nucleus basalis of Maynard, which is an acetylcholine producing center, which is a memory center. The pedunculopontine nucleus within the pons is also a cholinergic center, which regulates our activity. Our ability to stay paralyzed during REM sleep is also affected, right? So it's not all about dopamine and understanding the neurotransmitters, and in particular, looking at serotonin and its role in the recent years has been helpful in understanding the utility of utilizing medicines that are not necessarily related to the other chemicals, but if we might have a serotonin receptor modulating agent, for example, that might help us with things like Parkinson's disease psychosis. So the recommended approach to Parkinson's disease psychosis is first identifying, ruling out reversible causes, understanding that it truly is part of the disease, not part of the medications that we might use, like all the medicines that we talked about, anticholinergics, amantadine, COMT inhibitors, the MAOB inhibitors that we mentioned in the previous study and the previous presentations, dopamine agonists, even levodopa. When we think about its utility, all of these medications carry the risk of enhancing or producing psychosis or delusions in our patients. So we have to constantly screen for that. And then we think about trying our best to use non-pharmacologic measures to treat patients, of course, but then thinking about the treatment options in the setting of our clinical regimen, armamentarium of medications. We think about clozapine, quetiapine, and more recently, pimavanserin. Understanding that Parkinson's disease psychosis is on a spectrum. We talked a little bit about kind of what a minor illusion might look like. You know, if you look outside and you see that a tree might look like a person for a moment, having hallucinations and retaining insight. Patients might be able to retain insight and understand that hallucinations might happen and they know their hallucinations. And then if we start losing insight and start changing our behavior, that's a very, very important thing to determine. Remember, we use this iceberg analogy. Here you can see that presence hallucinations, visual illusions, and passage hallucinations might just be the tip of the iceberg associated with this complex of REM behavioral sleep disorder, cognitive impairment, depression, larger scale neurocognitive dysfunction of the networks. And so remember, the neurobehavioral part of Parkinson's disease is so, so important. That neurobehavioral, that neurocognitive aspect, so important. So what do we use to treat Parkinson's disease psychosis? Right now, in terms of the last update by our movement disorders team, what we see here is that pimavanserin has been shown in pivotal studies to be clinically useful, efficacious. It's a 5-HT2A inverse agonist, so it very much works on that serotonergic system that we briefly discussed. We can see that there might be this upregulation of these 5-HT2A receptors in certain parts of the brain for Parkinson's disease psychosis. So modulating the 5-HT2A receptors might be useful based on the clinical data. We do use medications like clozapine, but we have to kind of monitor risk and benefit. Remember, we would need, in clozapine's case, regular blood draws can be done weekly because the risk of agranulocytosis exists. And so that is something that has been shown to be clinically useful and efficacious, but does carry a risk that needs to be monitored for. Quetiapine has been, at least in terms of practice implications, have been shown to be possibly useful, not clinically useful like we see with pimavanserin or clozapine. And there is insufficient evidence based on guidelines, but it is something that is mentioned as part of the clinical options when it comes to treatment of Parkinson's disease with psychosis. And so even when we're considering deep brain stimulation, that neurocognitive aspect, monitoring for cognitive change can be very important in making motoric therapeutic decisions, right? So if a patient has moderate to severe dementia or moderate to severe depression, that might preclude them from being candidates for deep brain stimulation. So when we think about all of the cognitive and then now psychiatric changes that happen in Parkinson's disease, remember, mood symptoms based on this 2019 guideline set, what we see here is that medications like dopamine agonists might be helpful or clinically useful for improving mood. We might think about monoamine oxidase B inhibitors, selective serotonin reuptake inhibitors. There's data to suggest that medications like venlafaxine or other SSRIs, citalopram, escitalopram, can be possibly to clinically useful. And so all of these things are important in addition to things like cognitive behavioral therapy. Remember, it's not all pharmacologic, despite talking a lot about these advanced therapeutics. Now, when we talk about treatments for depression and sleep, we talked about SSRIs, SNRIs. Remember, benzodiazepine like clonazepam can be used for REM behavioral sleep disorder, as we mentioned. Melatonin can be useful. Things for sleep onset insomnia. Mirtazapine and trazodone have been studied in Parkinson's disease, potentially to be clinically useful. And I'll leave us on one important note that a lot of our care, in 2020, 2021 was provided virtually, and it did almost launch us into this whole world. Look, now we're doing a CME course virtually, which we want to do in person, of course, as well. But when we think about the amount of education, the amount of connection we can have with our patients, the amount of things that we can screen for, even virtually, without having our patient, especially with neuropsychological, neurocognitive, neurobehavioral changes, patients that might come into our office regularly. But a lot of the times this kind of more touch points, more longitudinal care, maybe more frequent check-ins with our patients might lead to more therapeutic success, right? A lot of what we do is very detail-oriented. And so let's not forget the amount of care that can be given from a speech therapy standpoint virtually, if we can help our patients really kind of grasp the importance and the power of telemedicine and telerehab and telescreening. you can even do examinations of all sorts, like we mentioned today, remotely. And so that's one of the positives about the movement disorders world, is that a lot of what we gather is very much based on history. Now, let's not forget all the important things that we do on examination as well. So I'll leave us there, and I wanted to thank us so much for being part of this wonderful presentation and being part of this group of people that are learning about advanced therapeutics in 2021. It's such an important field. It's such an important subspecialty. It is therapeutically vibrant. There's a lot we can learn from our data and our guidelines. There's a lot of data out there. Funneling it all together, creating an advanced therapeutics kind of understanding of how we treat Parkinson's disease, not just the motor symptoms, but the non-motor symptoms. And now we learned about the cognitive aspects. This is just, again, the tip of the iceberg. We can talk about this for days, and we can really dive in and understand the therapeutics and really go beyond the surface when it comes to that. So I want everyone to feel empowered and wonderful after this CME course. Hopefully we touched on a lot of important topics, but it helped us understand that there is hope and there's positivity behind these advanced therapeutics. Have a wonderful day.